Well, hello. This is part 3 of the articulation and resonance unit, and we are going to speak about continued tongue muscles, and then we are going to discuss velar or soft palate muscles, and then we'll look at pharyngeal muscles. So, in terms of the tongue is the most important articulator, and one of the reasons is that it is very flexible, and it can move forward, backwards, up and down, and you can just simply think about, say, all the sounds, and think about the tongue and see what sounds the tongue contributes to. Of course, all vowels. You know, the tongue shapes all the vowels, 14 vowels. Think about the consonants. Begin from your lips and say all the sounds until you go to the very end, to the vocal folds. What sounds does the tongue contribute to? For example, when you say p, b, of course you don't see tongue action here. F, v. But once you say th, the, then the tongue is active. I mean, is obviously active. When you say all the alveolar sounds, t, d, s, z, all the palatal sounds, you cannot do them without the tongue. And then the velar sounds, k, g, you can't do that without the tongue. So the tongue is a very important articulator, but it does more than that. It serves biological functions, for example, in feeding and swallowing. So feeding and swallowing, tasting, these are the basic biological functions of the tongue. When it comes to speech, the tongue serves as an articulator. Again, the most important articulator. That's one speech function. And the second one is that it modifies your voice. It modifies the vocal tract, and this way it modifies your pitch. So when the tongue, for example, moves forward in the oral cavity, you have the resonance frequency, or the kind of pitch in the front of the oral cavity here. That's going to be like higher pitch if the tongue fills it. If the tongue goes back and goes up, the front here, you will have lower pitch. So anyways, you'll study this in speech and hearing science. All I want you to know is, for the purposes of AMP, is that the tongue modifies the vocal tract and modifies pitch or resonant frequency of the vocal tract. So 2 speech functions and 2 biological functions. You can see now, here is the tongue itself, the muscles of the tongue here. We call the muscles of the tongue that make the tongue piece itself, that you can, kind of stick out like that. These are intrinsic tongue muscles. The muscles that come from somewhere else, originate somewhere else, and insert onto these intrinsic tongue muscles, we call these extrinsic tongue muscles. And the same principle. Extrinsics have an origin, usually an origin somewhere else, and they insert onto the organ itself. And the intrinsic, both the origin and attachment are on the organ itself. So the same thing that we spoke about when we talked about muscles, for example, of the larynx. So examples of the extrinsic muscles, you can see here, this is the styloglossus, hyoglossus. So these originate somewhere else and insert onto the tongue, genioglossus. So let's go and start looking at each one in detail, and you need to know the origin and insertion, and in terms of anatomy, and also the physiology or the function of the muscle. So there are 4 extrinsic tongue muscles, and there are 4 intrinsic tongue muscles. The first one of the extrinsic tongue muscles is the genioglossus. The second one is the hyoglossus, and then the palatoglossus and the styloglossus. Let's use the image so that you can relate to the muscle more. And then I'll explain the muscle and each muscle and its function. So the first one, the genioglossus. Genio, the chin bone basically here. And the muscle originates on the inner surface of the chin bone. And it fans posteriorly and superiorly. So it goes almost like this when you see it under the, if you move some of the tissue of the tongue, you're going to see it fanning back and going like this. So for example, and the tongue is sitting on it. So if that muscle contracts in certain ways, it's going to enable you to stick your tongue out. And also it enables you to put pressure on the alveolar ridge here. The genioglossus is the largest tongue muscle, and it basically serves as the foundation for the tongue. You could see the parts of it here. You can see, and the whole tongue is sitting on it here, and here as well. So the functions of the genioglossus in terms of speech. It enables us to protrude the tongue out of the teeth. Like when I say the genioglossus enables you to do that. Stick the tongue out between your teeth, and that's going to enable you to say the. To also put your tongue at the alveolar ridge and compress, put pressure. So when I say s, z, sh, and then you go to the palatal sounds also, sh, zh, and then d, j. So all these sounds are actively produced with the help of the genioglossus. Then the hyoglossus. The hyoglossus from the name itself, you can tell that it originates on the hyoid bone, and it rises and goes anteriorly, slightly anteriorly, so it's at an angle like this, and it inserts onto the posterior 1/3 of the tongue, onto the sides of the tongue, and the posterior 1/3. So when it contracts, it's going to pull the tongue in 2 directions. It's going to pull the tongue down and back. Any muscle that is tilted, that is at an oblique angle, when it contracts, it's going to pull in 2 directions. For example, the styloglossus, it comes down at an angle, and when it contracts, it pulls the tongue back and up. So think about what sound do you make that requires the tongue to go down and back. Think about the vowels. So when you say ah, the tongue, the hyoglossus is going to pull the tongue back and down, and that's the lowest back vowel. When the tongue goes back and down. And this is why when you go to your doctor, they usually, and they want to ask, to see, to visualize your pharynx, they would ask you to say ah, basically to take the tongue out of the way. So the tongue, the The tongue moves back and down, and the action is performed by the hyoglossus muscle. So I'd like you to know what sounds are associated with what muscle. So this muscle enables us to say sounds like ah. And then we have the styloglossus. Here's the styloid process. And this muscle originates there and then courses inferiorly and anteriorly, and it inserts onto the posterior lateral margins of the tongue. So when it contracts, it's going to elevate the tongue and pull it back. And so here is it again. It is again styloid process, and then the styloglossus muscle here. So I added a couple of images. I hope they do not disorient you. The information is the same. It is just a couple of images to make things clearer for you. So this, you can see the U, and if you have taken phonetics and you look at the quadrilateral, you are going to see that the U is a high back vowel. The way you can make this vowel is to pull the tongue back and up. So you bring the tongue up and back with the help of the styloglossus muscle. So again, know that these muscles, extrinsic tongue muscles, one of the main functions of them is to enable or to move the tongue, to move the tongue forward, back, up and down, and to do the kind of the heavy lifting of the tongue. And that is, they are essential for articulation. And know what muscle enables us to do what sounds. The same muscle enables us to make vowels, the back vowels basically. The O as in rose or Melrose, the O as in law, and this one is a different one. So, but the ones that require the tongue to be elevated and coming back, like the U particularly, the styloglossus is essential for making it. And then, so 4 muscles. We discussed the genioglossus, hyoglossus, styloglossus, and then the palatoglossus is the 4th muscle. This muscle originates on the anterior borders of the soft palate, particularly on the palatal aponeurosis. So on the sides of the palatal aponeurosis, you can see the origin here. And then it courses downward and it inserts onto the posterior lateral margins of the tongue. So the muscle basically is like this. And you can see, so here is the muscle. And you can see it when you open your mouth and look in the mirror. So go back. Where is it? I'll show you the image here. I think I have an image I'm going to show you. I promise. Okay, so when you look here, this is the fascial pillar, one side, and then the other side. If you remove the epithelial tissue here, the cover, you are going to see the palatoglossus muscle there. So the palatoglossus muscle makes the anterior wall of the fascial pillar. Okay? And again, it originates on the palatal aponeurosis, courses downward, and inserts onto the lateral posterior margins of the tongue. So when it contracts, if you fixate the top part, the palatal part, you are going to elevate the tongue. If you fixate the lower part of the palatal glossus, you can lower the velum, because both the tongue and the velum are flexible. So you can do two things with the same muscle. Let's go back. So now let's move on to the intrinsic lingual muscles or tongue muscles. The tongue is made out of four intrinsic muscles, basically two, a muscle that has fibers coming from back to front, all the way back to front, and there are two there's one on top and one on the base of the tongue. So they are like this, and they're connected at the tongue tip like this, and these are called the longitudinal tongue muscles, because the fibers go from front back to front. And because there are two of them, one on top on the like making the superior surface of the tongue, and one making the inferior, we call the top one the superior longitudinal tongue muscle, and the lower one we call it the inferior longitudinal tongue muscle. So they are like this. In between them, you are going to have the vertical tongue muscle. Vertical, it spans all sides. I mean, as you can think of it, as I explained in the class, like the coils of a mattress. They spread all over the mattress, connecting the top to the bottom. So connecting basically the longitudinal with the superior with the inferior longitudinal muscles, and filling in the space, but the muscles are oriented like coils of a mattress. And then we have the transverse. The transverse goes from side to side, side to side. It is important that you visualize these muscles, and if you visualize them and think about them, you really wouldn't have to memorize their function, at least. Think about a muscle that goes from side to side. When muscles contract, what do? They shorten, they become shorter. So when this transverse tongue muscle as it contracts, it's going to narrow the tongue. So when you narrow the tongue, where does the tissue go? So when you narrow it, the tissue is going to spread downward, and then it's going to spread forward. And by doing so, the transverse muscle, when it contracts, is going to narrow the tongue, and by doing so, it's going to make it longer, narrow and elongate the tongue. Now look at the vertical muscle. The vertical muscle goes from the inferior to the superior longitudinal, and when that muscle contracts, it's going to become shorter. What does it do? So it's going to bring the superior longitudinal closer to the inferior longitudinal. It's going to make the tongue thin, and the tissue then will spread sideways. So as you see here in the image, it flattens the tongue. how does the superior longitudinal muscle, how does it behave? How does the inferior longitudinal muscle behave? Because they are connected at the tongue tip in the front. And so when you contract one side, the superior longitudinal muscle, it's going to basically it's going to move the inferior one. So let's try. The superior is going to contract, and you could see now lifting the tongue tip. So this muscle is going to contract, the superior contraction will elevate the tongue tip. And when the inferior muscle contracts, it's going to lower or bring the tongue tip lower. So they reverse the function of each other. Contraction of the superior is going to elevate the tongue tip, and contraction of the inferior muscle is going to bring the tongue tip down. So you can imagine now that the superior longitudinal muscle contributes to alveolar muscle sounds and to palatal sounds. Okay, now we move now to the mandibular muscles. The mandible has many areas. I added a couple of images again, so that I hope they don't kind of disorient you. And you can see different structures of the mandible. We know that the vertical piece of it is here. That's called the ramus of the mandible. The frontal part here is called the inferior frontal part is called the body of the mandible, and it has different landmarks. So how does the mandible contribute to functions like feeding, swallowing, speech? The primary function, of course, is a biological survival function, which has to do with chewing food and preparing food for swallowing, which is mastication. The speech function and the voice function, let's say speech, because voice is part of speech. Number one, you have the mandible as an articulator, and then you have also the mandible as an organ that contributes to shaping the configuration of the vocal tract. The vocal tract is going to resonate differently. It will change its sound differently based on the diameter of it. Is it wider? Is it constricted? Is it longer? Is it shorter? And so on. And you can simply just test by saying E. When you say E, where is your mandible? Is it up? Is it down? E. How about when you say ah? Does the tongue, the mandible go down? Is your mouth opened? All of these movements by the jaw are going to affect your pitch, your resonant frequency of the vocal tract. So it modifies your speech, and it enables you to articulate. One of you asked, is the mandible a mobile articulator or an immobile articulator? Of course, when you look at it as a whole, as one piece, it is a mobile. It moves down, and it enables you to articulate, like ah, e. When you look at different, specific parts of it, then these are immobile. For example, when you make the th, you need to bring the lower teeth and up to a certain distance from the upper teeth, front teeth, and then you put your tongue between. So in that case, the lower teeth are immobile articulators. They don't move, but they are part of the jaw. So it depends on if you look at the jaw as a whole piece or as parts. You look at, a part of it. So if you look at a part, that part doesn't move, but the jaw itself as a whole does. The movements of the jaw are three. So the jaw can be elevated and it can be lowered. So elevation and depression and rotation. So when you chew, watch anyone who's chewing. They don't go like this. They don't go like this. They go up and rotate, up and rotate. So crush food and rotate to grind it. The mandible is connected with the skull through the temporomandibular joint. Temporal is from the temporal bone, and mandibular comes from the mandible and the joint, of course. And many people know this as TMJ. However, whenever you say TMJ, you might just immediately think about the disorder. So TMJ disorder is the disorder that involves abnormalities of the temporomandibular joint. So now we know bones cannot do anything. Bones just like a stone. You put a stone somewhere, it's not gonna do anything. It's not gonna move. It's not gonna do anything. Cartilage, you have to have muscles, and muscles also can't do anything at all on their own. You have to bring in electrical signals from the nervous system to activate the muscles. And then the muscles will move the bones like the mandible or cartilage, whatever it is. So what muscles act on the mandible to enable it to perform its function? We have muscles that elevate it and muscles that basically depress it. And so the mandibular elevators include the masseter, the medial pterygoid, and the temporalis. And we showed this in class. You just go to the video. It demonstrates the movement of the temporalis muscle. So the masseter is this muscle. You can feel it, you can see it when people go like this. You can see it in the mirror, you can feel it here. And it originates above. It makes sense because if the origin is above, now it's gonna pull up. I also changed the chart here. I gave you a more of a friendly chart. So the masseter originates on the zygomatic bone, the cheekbone, and then it goes down and a little bit posteriorly to insert on the posterior inferior segment of the posterior lateral segment of the mandible, between the ramus and the body of the mandible here. And of course, the function is to elevate the mandible. And then the medial pterygoid. The medial pterygoid, I have some images here, but here. So the pterygoid muscles, you have the lateral pterygoid muscle, and you have the medial pterygoid. So the muscles originate here and insert onto the jaw. So particularly the medial pterygoid inserts on the anterior surface of the ramus of the mandible here. So this is the ramus, vertical piece from here to here. and it inserts onto the anterior inferior surface of, just say, the anterior surface of the ramus of the mandible. And the function, of course, is to elevate the mandible. It has two segments, but you don't have to worry about it be having, two segments. Just know the basics that I mentioned. And then the temporalis. This is the most powerful muscle that originates in the temporal bone here, goes down, changes into a tendon, and inserts onto the mandible. You can't visualize it here, but I'm sorry, you can see it here, but you wouldn't see the connection, the insertion onto the mandible. But if you uncover, you take out the masseter, you are going to see it beneath the masseter here. So this is the most powerful muscle of the mandible, and it is what makes you bite. Like, imagine like having a nut to crack with your teeth. I hope you do not do that. Or look at, say, monkeys or gorillas when they bite and crush, things. That is what gives you the power of crushing things and biting hard on something. Okay, so now the primary function of this is to basically elevate the muscle and contribute to mastication. They enable us to crush food and to grind food. The depressors, we discussed all of this before in the context of the phonation, muscles of phonation. So the mylohyoid originates on the inferior lateral margins of the body of the jaw here, and then it courses medially and slightly down to insert onto the hyoid bone. And you can imagine now, previously we said this muscle can elevate the hyoid bone for phonation, or swallowing. And now we know that it can actually do another function. If you fixate the hyoid attachment, then you can bring down the jaw. Okay, so the geniohyoid. We also knew that muscle as a muscle that can act on the hyoid by elevating it and pulling it anteriorly. Now we know that if you fixate that hyoid attachment, then you can pull down the jaw. The anterior belly of the digastric is the same way. So the anterior belly of the digastric is one of the mandibular depressors. And we discussed the origin and insertion extensively in phonation. Please go back to the information about these muscles. The velar muscles now. We're gonna discuss the muscles that make the velum and the structure and the movement of the velum. The velum is also called the soft palate, but the term soft palate, it doesn't allow you to make an adjective. So for that we have to go back to the Latin origin and use velum. So we say a velar muscle, for example, a velar sound, and so on. So the velum is made up of a band of fiber that connects the hard palate with the rest of the muscles that make the velum. So that band, soft tissue that is not bone, that connects the soft palate muscles with the hard palate, that is the palatal aponeurosis is considered as part of the velum because it's not hard, it's not bony. So the palatal aponeurosis connects the velum with the so if you can think of this as the hard palate, and then the movable piece will be the soft palate. On the border here between the hard palate and the soft palate, you have the palatal aponeurosis. And we'll discuss how it is formed and how it helps make the connection. So the velum basically is made out of a set of muscles, and these muscles are covered with an epithelial lining, mucous membrane that exactly is similar to what you find inside of your cheek, and also there are blood vessels, of course, and the nerve tissue embedded in there, so it can move the velum up and down and make it do its work. Also, there's some immune lymph or parts of the immune system vessels embedded in there, because to help with the immune system. And also there are some taste buds on the part of the velum that is facing the oral cavity. So as you are swallowing food, now you feel it. You feel the taste to the last bit of it, with the back of the tongue having large taste buds, and the velum, the surface of the velum that's facing the mouth, the oral cavity, also has some taste buds, so you can feel the taste from above and below. Okay, so you have a posterior view of the velum now, and you can see how it spreads from one side of the pharynx and oral cavity to the other, actually the pharynx, and it separates entirely. It can separate the nasal cavities from the oral cavities. So this velum now is down as you are, for example, sitting and breathing. But whenever you speak, it's gonna be lifted up, and it will separate the nasal cavity from the oral cavity, unless you say sounds like and what the velum will be like it is now when you make these sounds. This is the laryngeal inlet here, the larynx, and posterior to the larynx, right behind it, is the esophagus. So this is one part of the esophagus here. And you can see the posterior part of the tongue. If you elevate the velum up, you could see through the oral cavity behind the velum. So now we divide the muscles, or classify the muscles of the velum, into three sets. We have elevators, or muscles that elevate the velum, and then muscles that tense. The tensor muscle, basically, because it tenses the eustachian tube, but this muscle also contributes to the functions of the velum. And then we have the depressor muscles. So basically the primary ones are the muscles of elevation, muscles of depression. These are two here, the levator villi palatini, or palati sometimes, and the musculus uvulus. And then we have the tensor villi palatini, and then the depressor muscles include the palatoglossus and the palatopharyngeus. We just discussed the palatoglossus, and we mentioned how it can lower the velum or elevate the tongue. So let's begin. As I mentioned, muscles cannot move unless you give them an innervation. And all the muscles of the velum are innervated by a complex of nerve tissue that comes from two nerves. One is the vagus nerve that's embedded in the pharynx and palate and all different areas of the neck here, and another set of extensions or fibers comes from the nerve That's called the accessory nerve, which is cranial nerve number 11. And that's the nerve, for example, that enables you to shrug your shoulders, for example. It contributes to the movement of the neck, sideways, for example, like this. So fibers from these two nerves, they combine to make a plexus, to make a complex, and that complex, or the pharyngeal plexus, innervates all the palatal muscles except for the tensor villi palatini, and the tensor villi palatini is innervated by the trigeminal nerve. Trigeminal. Geminus means twin, and tri means three. So it's a nerve that goes like this, and the branch, innervates the lower, the mandible, and one innervates the maxillofacial area here, and one innervates the area that's around the eyes and the forehead, like this. Because you have three branches here and three here, and each one has a twin on the other side. So there's one twin, two twins, three twins. So that the nerve that has three twins, the trigeminal nerve. So the levator villi palatini, that muscle makes basically the bulk of the velum, and we demonstrated it in class in the way that it looks very much like a hammock coming down, coursing down and anteriorly, and then the fibers connecting like this, and it is, when you contract, you elevate the entire velum. So, for example, here's the origin of the muscle is on the temporal bone. This area is called the petraeus, or the hard, portion of the temporal bone, and the muscle courses inferiorly and anteriorly, and the fibers go cross to connect with the fibers on the other side under the muscular sevillas. Let's go back. No, actually it's gonna be here. So here is the muscle originating on the petraeus. That doesn't show it has two origins. One part is on the wall of the eustachian tube, but also it has another connection that's not showing here on the petraeus portion of the temporal bone, which is here. So when the muscle contracts, it's going to elevate the velum from two sides. It's just like a hammock, and they elevate and pull back. Because your goal, the velum is like this, the back of the back wall of the posterior, or the posterior pharyngeal wall is like this, and you want to elevate the velum, make it seal against the posterior pharyngeal wall. What is the name of the space between the posterior pharyngeal wall and the velum? Remember, this is a very important space. The velopharyngeal port. So elevating the velum is going to seal, to close off the velopharyngeal port, and it will enable us this way to separate the nasal cavity from the oral cavity. So again, this muscle originates on the originates on the temporal bone, and also the medial wall of the eustachian tube. So it has 2 points of origin, and it courses downward and forward to insert onto the palatal aponeurosis. So we'll go back again, forward again, and you can see the palatal aponeurosis is all this fiber here, the white tissue here, and I explained also how it is formed by the tensor villi palatini here. So if you take out this tissue of the levator villa palatini, take that tissue out, you still find the aponeurosis underneath, because this muscle is inserting onto the palatal aponeurosis and under the uvulus, muscular sevillas. So, so this muscle, again, it enables us to, it enables us to elevate and to retract, elevate and retract the velum, so you can close the velopharyngeal port. The muscular sevillas. Let's go back to the image and I'll explain that there. The muscular sevillas is here. If you look at the two sides of the nasal cavities, left, right, and left, the wall in between, I hope you remember this very important bone. What is the name of the bone that separates the nasal cavity into two chambers? So I'm going to ask you to look at your notes, and I'll leave this because of the importance of this muscle, this bone. I need you to find out and to remember from the class what it is, this plow-shaped bone. At the point where the posterior part of this bone fuses with the palatine bone here, that area is called the posterior nasal spine. So the muscular sevillas originates on the posterior nasal spine. Let's go, I have another thing here. So here is the margin of the palatine bone here, and the palatal, the fibers that make the palatal aponeurosis, they insert here and here. But on this point, on this tip here, you are going to have the posterior nasal spine. And on the posterior nasal spine, you have the muscular sevillas originating right here. That is the only area where the tissue of the palatal aponeurosis is not inserted onto the edges of the palatine bone. So, let me go back again. Here, if you look here, the fibers are coming in and so on, and they kind of stop here. I mean, they don't stop right there, but what they do is they go around the muscular sevillas origin. So here is the only area you could see some of the tissue of the palatal aponeurosis. Because of that connection, then the palatal aponeurosis fibers are going to go beneath the uvula, beneath the muscular sevillas, and connect with the fibers from the other side. So also going above the muscular sevillas and connecting with the tissue on the other side, thus creating a tunnel around the anterior part of the muscular sevillas. And this way you can imagine now that if I am making a tunnel like this around the structure, let's say like this, I can now provide support. I can now contribute even to lifting it up or bringing it down, so I can support the muscle from the origin here by simply having this, or how the palatal aponeurosis goes above and below and connects around it. The muscular sevillas, even though it looks like one structure, you can simply say it's unpaired, but it has in the middle, in the center, there is a line where it actually is two sides, right and left, and so two sides. And if you refer or see the name musculus uvulae, with an AE at the end, then no, it is the same muscle, but we are thinking about the two sides of it. Why is it important, when you say muscular uvulae? If someone has paralysis on one side because of, a stroke or something, they might have one side only of the muscular sevillas impaired because of the innervation coming from one side. It's going to take that half, and the innervation from the other side is going to take the other half. But you wouldn't have to worry about this at this point. You can refer to this as the muscular sevillas. And if you see it again, someone referring to it as muscular uvulae, know that it's the same muscle. This muscle, how it functions, just like I demonstrated earlier, when it contracts, it's going to contract the upper fibers, and the upper fibers. When you do that, then you elevate the velum. So again, like that, and then it contracts, and the upper fibers are going to contract and shorten, and that's going to elevate the velum. And by doing so, you help. It works with the levator villi palatini, and it helps it elevate the velum and kind of tense it, bunch it up. The tensor villi palatini is a muscle that, again, it has two origins. One origin on the sphenoid bone, and the other origin is on the lateral wall of the eustachian tube. And here, so you can see now the eustachian tube, this opening here, and there's a cartilaginous wall where the two muscles actually are. The levator villi palatini is attaching all along the lateral wall of the eustachian tube, and right behind it is the tensor villi palatini, and the insertion is all along the cartilaginous segment of the eustachian tube. So when you take that muscle and contract it, it's going to tilt the eustachian tube down because it shortens. It's going to tilt the eustachian tube down. By doing so, you are going to open the mouth of the eustachian tube. So you can't visualize it now unless you take out the levator villi palatini. So let's look here. Now we have taken out the levator villi palatini, and then you can see now the eustachian tube, and all on the margins of it you have the attachment of the tensor villi palatini. So it actually tenses the eustachian tube, and by doing so it tilts the mouth of it open. And the reason we open, we have to have the eustachian tube closed all the time, is that if you had it open, the voice of the vocal folds is very loud, and as you vibrate your vocal folds to make sound, the sound is going to go up directly to the nasopharynx, and it directly is going to go and activate your ear, and it's going to, the vibration will go, and then basically very early in life the person could be deaf because of their own sound. Listening to their own voices, they could simply become deaf. For this reason, the eustachian tube is more like a deflated fire hose that's closed most of the time, and it only opens when you swallow, when you yawn, or when you are doing things that are not speech sounds, that you are not making, you are not using your vocal folds, basically are not producing speech. So this is as a way to get the air in, to ventilate the middle ear and make it function well without compromising your hearing. Now, you could see as the tensor villi palatini comes down and it courses down and anteriorly, it is going to come to an area that's called the hamulus of the pterygoid bone. It's part, it's like a tip of bone sticking, out like this. And the muscle comes in. As it comes close to the bone, it turns into a tendon. And the tendon goes under the pterygoid, the hamulus. And then it shows up on the other side and it fans out and inserts onto the edges, the posterior edges of the palatine bone, and it forms the palatal aponeurosis. Let's go back and see the clearer image here. So the muscle again originates on the sphenoid and the lateral wall of the eustachian tube, and then it courses downward. And when it comes to the palatal, hamulus, it's going to go beneath it, and it shows on the other side as, the tendon shows on the other side and fans out and inserts onto the posterior margins of the palatine bone, and then it makes the palatal aponeurosis this way. And that serves as the connection for the other palatal muscles. And as you could see, the elevator villi palatini now is all inserted on the palatal aponeurosis. And as I mentioned, the palatal aponeurosis covers all these areas except for the point of connection where of the muscular sevillas. All right, so the functions of this muscle is to flatten and stabilize the velum and to dilate the eustachian tube, to open it, to assist in regulating middle ear function in terms of ventilation and having the air pressure equalized. So in order for the tympanic membrane to function well and for the auditory system function well, you have to have equal pressure around the tympanic membrane, around the eardrum. So in the ear canal, the air in the ear canal is equal in pressure to the air inside of the middle ear, and that ensures that the air is circulating in the middle ear. Here's the velum. If you look at it laterally, and this is the hard palate, this is the soft palate. When you elevate the velum to close off the velopharyngeal port, the velum seals against this bulge that we know as the adenoid pad. Very important. And this is gonna the velum will be elevated with the help of the muscles that elevate it, and it seals against the adenoid pad. And now you can produce speech or when you swallow as well. And the palatoglossus, as I mentioned, I just spoke about the origin earlier, and here it is. The functions of it is to either elevate the tongue or to depress the velum. So it contributes to speech, it contributes to also to regulation of, resonance, and it also contributes to swallowing as well. The screen seems to have frozen. Okay, and you can see now the anterior facial pillar is here, and when we speak about the pharyngeal muscles, we are gonna come back to this and we speak about so this is the anterior facial pillar wall, and then in the back you have the posterior wall that is made out of the palatopharyngus, and we'll discuss it when we come to that point. So here is the palatoglossus, and posterior to it you have the palatopharyngus. The palatopharyngus originates on the anterior lateral margins of the palatal aponeurosis and in the posterior lateral margins of the hard palate. So right there. So the upper fibers cross over and connect with each other on the other side, so around the palatal aponeurosis area. So for some fibers from the palatopharyngus, the upper fibers cross over and interdigitate like this. Interdigitate means connect like my digits are connected now with the other side. So they form part of the velum itself, part of that structure, the roof of your mouth, some of the fibers. And then the other fibers go downward and posteriorly and to insert onto the pharyngeal muscles. This is where palatopharyngus. And some of the fibers insert onto the posterior margins of the thyroid cartilage. So here is the muscle again. And as it goes down, you can see these are the pharyngeal constrictors that we'll discuss shortly. And the muscle inserts onto them, and some of the fibers go down to insert onto the posterior walls, the margins of the thyroid cartilage. Here again is the muscle, palatopharyngus. So now you can imagine when you elevate, you contract the muscle, you are going to elevate the pharynx, and you assist in narrowing the pharynx down. And also, if you fixate the lower attachments, you can lower the velum. So this muscle again can either lower the velum or narrow the pharynx and elevate it. Now, let's look at the pharyngeal constrictor muscles. Obviously, the pharynx is made out of a posterior pharyngeal wall that you could see when you say, you can see the back of your pharynx. The back of your throat, you can see the part of the pharynx. And then you have the left lateral wall, pharyngeal wall, and then the right lateral pharyngeal wall. So two lateral pharyngeal walls and the posterior wall. There is no anterior wall, obviously, because we have the mouth and the nose and all of this. So how these muscles form? The space, the pharynx, is a space. And it is a space that is surrounded and made by the pharyngeal muscles. So the pharyngeal muscles kind of are shaped like this. They originate and they kind of curve like this. Each muscle is going to do that. And they fuse in the back of the pharynx. Now you have a posterior pharyngeal wall where the muscles from each side are fused with the other side. And then you have the lateral walls. So we have the superior constrictor, the medial and the inferior. And from the name, you can see now that these muscles actually constrict, narrow down. When they relax, the pharynx is dilated. When they constrict, they narrow it down. So if you look here, this is a posterior view of the pharynx. The superior segment of that wall is the superior constrictor, the superior pharyngeal constrictor. You can see the fibers are oriented almost horizontally. And posterior to it is the medial pharyngeal constrictor, coming down like this and kind of fanning in a triangular shape. And the fibers are more kind of oblique. The muscles support each other like fabric when you make it. And then posterior to and inferior to the medial pharyngeal constrictor, you are going to find the lower pharyngeal constrictor. So the superior pulls the pharyngeal walls forward and constrict the pharynx when you swallow. And it also helps in closing the velopharyngeal port. For example, when the okay, let's just move on, and then we'll tell you more about the different functions. But the middle also helps in limiting or narrowing the diameter of the pharynx. So here, the inferior has two segments. One, if now only focus on the inferior as we discuss it here. One, the upper segment of the inferior pharyngeal constrictor is here, and it forms, it works a similar function like the other ones. The lower segment has its own name, and it's called the cricopharyngus here. So it is like a C, shaped like a seashell. And from the name, you can now see that it originates on the cricoid cartilage, and it fans posteriorly, and then the two sides connect like this. So the muscle is like this. And when it contracts, it's going to narrow the upper segment of the esophagus. Because, see this muscle here now, this is the esophagus. And this muscle controls the upper segment of the esophagus. It is called the upper esophageal segment. And you could see now that it contributes to swallowing. It's very important for swallowing, the cricopharyngus. It squeezes whatever food or liquid that you have, squeezes it down into the esophagus. So we know that the esophagus is not opened like this. The esophagus is like a deflated fire hose that is closed most of the time like this. It opens only when you put something onto it. When you put something onto it, for example, the food is coming down, it's going to, you close from the top, close using the cricopharyngus, and as you close, it forces the food down into the esophagus, and then as the bolus or the food goes down, the top or the area behind or above the bolus is gonna close. So it keeps closing, 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 and that is called peristalsis, and it propels the whatever you are swallowing in the direction of the stomach. Even if you are standing on your head, the food or the liquid, whatever you are swallowing, is going to continue to rise to the stomach. Amazing, isn't it? So this is the cricopharyngus muscle, again, very important for swallowing. And it is the area, it controls the area of the lower pharynx, which is the borderline between the pharynx itself and the esophagus. So it makes the lowest part of the pharynx, and it forms also the upper esophageal segment. And that is, if it is impaired, it is going to affect swallowing functions. The stylopharyngus is a muscle that we discussed again before, and here it is, originates on the styloid process, courses downward, and inserts onto the walls, onto the pharyngeal constrictors, and also parts of it will insert onto the posterior margins of the thyroid cartilage. And the function is to elevate and to open the pharynx for swallowing. So the food is coming down, you elevate the pharynx to kind of assist, and when you elevate, you kind of dilate, and then the food goes in, and then you lower. You can try it. Swallow, and the pharynx is gonna, the whole larynx is gonna be elevated up, and so now in the last couple of minutes we are going to speak about the stages of swallowing, and this is just a very, very basic introduction to swallowing, to kind of connect what we are doing, all this the muscles that we have discussed with the swallowing functions. When you go to grad school, you should have a course in swallowing, feeding and swallowing disorders. So the first stage of swallowing is putting the food inside of the mouth. Once the food is in there, you are going to basically prepare it to swallow it. So that's called the preparatory phase, or the oral prep phase. And it begins with crushing the food and then grinding it and making it, ready to swallow. And it involves a lot of activity of the intrinsic tongue muscles and also the extrinsic, but the intrinsic are very active. You do not necessarily feel their movement unless you have anesthesia that's affecting tongue function. And then when you start biting the tongue, and you can see now that we do all of these movements as we swallow, where the tongue basically makes the food it undulates, like making wavy movement from side to side to make the food go to the center of the tongue, like this. And it also moves, making wavy movements from the front to the back, and it will make the food act as a slide for the food to slide on it to go down to the pharynx. The oral prep phase ends when the food or liquid, whatever you are preparing to swallow, is formed into one cohesive bowl or bolus, and that will be ready on the center of the tongue and ready to swallow. So when that is where this phase, now you start, once you start moving it, and it reaches the end of the oral cavity where the facial pillars are, this is where the oral prep stage ends. I needed to be prepared to discuss each stage. The pharyngeal phase begins, you can see now from the name, it has to do with the pharynx. It begins when the food reaches the facial pillars or passes beyond the facial pillars and activates the swallow reflex when it hits your uvula. Now the swallow reflex is activated. This is, at this point, you have no control over the bolus now, and then you are going to swallow it. At this point, what happens during this very, very important stage? Number one, breathing stops. Because if you swallow when you are breathing, food is going to go right into your vocal folds. And that is going to cause you to choke, and it would be very dangerous. So breathing stops. And the epiglottis covers the laryngeal inlet to protect the opening of your airway. And food is going to go on top of the epiglottis. We discussed the epiglottis extensively in phonation. So the food, it has two grooves on top of it, left and right. And the food or liquid are going to go over, onto these grooves and onto the pharynx, directly onto the pharynx. And then at that point it's going to reach the upper esophageal segment. The cricopharyngus is going to contract, and it will squeeze that, whatever you are swallowing, it will squeeze it into the esophagus. And as the food crosses the upper esophageal segment, as it crosses the lower part of the pharynx and enters the esophagus, this stage ends. So I'd like you to know the steps of these very important phases of swallowing. And then in the esophagus, once the food enters or passes through the cricoesophageal pharyngeus muscle and into the esophagus, that is where the esophageal stage begins. And the food is propelled through peristalsis into the esophagus, until it passes through the lower esophageal, the lower esophageal segment, where there's a kind of a valve that allows food to go in and then it doesn't go back. So it closes the lower part of the esophagus that leads into the stomach. So again, this stage involves food passing through the esophagus. Once it enters into the stomach, then swallowing is over. Okay, so you could see now how the tongue, for example, after you prepare the food and stuff, and then the tongue is elevated, see, up and acting like a slide, and then the velum is closed. I'm sorry, the velopharyngeal port is closed, sealed shut, because air dynamics are important. And then the food starts now to go into the pharynx as it is now. So now, as it approaches, it goes the beginning of the pharyngeal phase. Now you can see the epiglottis now starting to tip over, and it's gonna tip over to close, to seal, protect the airway, which is here. You can see now the airway is covered, and then the liquid is going down here. And you could see now when you swallow, how you swallow the velum down, you swallow it with basically, so you can close everything here. And then the food is now going into the esophagus. You can see now it is crossing here, crossing the cricopharyngeus area here. And then now that is the beginning of your esophageal phase of swallowing. And you could see how the esophagus closes on top, of the bolus, and it keeps closing and closing. As it is closing, it is propelling, it is driving it into the direction of the stomach. We know this as peristalsis. If you don't know how to spell it, please Google it. Thank you.